afternoon. My name is Alea, and I will be your conference operator today. At this time, I would like to welcome everyone to the 2013 Post-ASCO conference call. At this time, I would like to welcome everyone to the conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, please press the pound key. Thank you. I would like to now turn the call over to your host, Ms. Shelby Monier. Ma'am, you may begin.
Hi, everyone. Good afternoon. Thank you for joining us for the Post-ASCO Teleconference brought to you by the Melanoma Research Foundation. Again, my name is Shelby Monier. I'm the Education Program Manager for the MRF. We were founded more than 16 years ago, and we have become a leader devoted to melanoma education and research in the U.S. Our mission is three-pronged. We support basic and clinical research, educate patients and caregivers, and advocate for the melanoma community. So your participation in today's call is really helping us achieve an important part of that mission. I'd now like to introduce the leaders for today's call, Dr. Lynn Schuchter and Dr. Leslie Fecher. Dr. Lynn Schuchter is a professor of hematology and oncology at the University of Pennsylvania and is chief of Hematology Oncology Division and the program leader for the Abramson Cancer Center's Melanoma Research Program. Dr. Schuchter is also on the MRF Board of Directors and is the co-chair of our Scientific Advisory Committee. Dr. Leslie Fecher is an assistant professor of clinical medicine and dermatology in the Division of Hematology Oncology at the Indiana University Simon Cancer Center, and she's specialized in the treatment of patients with melanoma and other advanced cutaneous malignancies. So I'd now like to let Dr. Schuchter begin with her updates on ASCO over this past weekend.
Thank you, Shelby, and I'd also like to extend my welcome to all the participants. We have been holding this conference call annually now for a couple of years. ASCO, which is the American Society of Clinical Oncology, is the largest organization of oncology investigators that brings together about 40,000 physicians and scientists and trainees to hear about the latest information in cancer research, with a lot of emphasis on advances in clinical research and clinical care. So this past meeting was held the first week of June in Chicago, and I have to say that the highlights from the meeting this year and last year were actually results related to the treatment of melanoma. So there were multiple sessions that were presented that really provided a lot of optimism about treatment of melanoma, as it talked about new approaches to immunotherapy, a treatment that revs up the immune system, and also new approaches to targeted therapy. And targeted therapy is where we understand the genes that are broken in a patient's melanoma, and then with more precision are able to tailor the therapy for that patient. We're going to focus today mainly on advances in the treatment of more advanced melanoma. Most of the studies we're going to talk about were for patients with stage 3 and stage 4 melanoma. Stage 3 patients who had melanoma that could not be removed surgically, and stage 4 melanoma is melanoma that has traveled through the bloodstream and is at distant sites. So today we're going to focus on updates from ASCO, and then we're also going to talk about 2 new drugs that were approved by the FDA for the treatment of advanced melanoma in the category of targeted therapies. So we have a lot to talk about in this short period of time, and as always, we're going to welcome your questions at the end of our presentation. So I'm going to first ask Dr. Leslie Fecher to give us an update on what she learned at ASCO, particularly the topics related to immunotherapy. And we're very fortunate to have Dr. Leslie Fecher join us today on this call. She is a phenomenal medical oncologist with expertise in melanoma. She trained at Johns Hopkins, was actually a faculty member here at the University of Pennsylvania, and is now doing really remarkable work at Indiana University. So Leslie, welcome, and we're anxious to hear about your information about new immunotherapy for melanoma.
Lynn, thank you so much for the invitation to participate. And again, thank you to everyone who has called into this teleconference. As I think all of you are well aware, it's been an exciting couple of years in melanoma, and I think it has continued, certainly reiterated by the data that was presented at ASCO this year. I'm going to speak briefly about the immunotherapies that have garnered the most attention. Melanoma is felt to be very closely related to the immune system and has been a subject for treatment with immunotherapies for quite some time. As was presented last year, there is a class of agents called checkpoint inhibitors. One of the medicines are CTLA-4 antibodies. Those include Ipilimumab as well as Tremelimumab. Ipilimumab is currently FDA approved for the treatment of advanced unresectable melanoma stage 3 and stage 4, and has shown response rates or shrinkage rates in the 10 to 15% range and an overall survival compared with vaccine therapy. At this point, it continues under investigation. Some of the toxicities associated with Ipilimumab and other CTLA-4 antibodies are what we classify as immune-related side effects that can mimic but are not the same as autoimmune toxicities and often require treatment with immunosuppressive medicines such as steroids. Another class of medicines that has been presented over the last few years are PD-1 or programmed death receptor 1 inhibitors that function similar to the CTLA-4 antibody but at a different process in the T-cell activation process. The idea behind PD-1 is that this functions later on in the activation process where there are exhausted T-cells. So these antibodies against PD-1 have been investigated, and preliminary data for some of them were presented last year with response rates approximately in the 29% range, with what appeared to be a bit less of the immune-specific side effects that had been seen before. One item that was presented at ASCO this year was long-term follow-up by Mario Snoll of the phase 1 study of Nivolumab, which is the Bristol-Myers Squibb PD-1 inhibitor. This was presented last year. They updated the response rate. Now this is a phase 1 study, so it included a variety of different doses of the medicine, and the overall response rate at all doses was updated at 31%. The median time of response for patients who evidenced benefit was 24 months or 2 years, with a median overall survival that was significant at 16.8 months. They also updated toxicity information, which overall showed fairly good tolerability with high levels of adverse events or toxicities that we call grade 3 or 4 in the 5% range. Another clinical trial, which was an expansion of a phase 1 study of another PD-1 inhibitor from Merck called Lambrolizumab, was presented by Dr. Tony Rebus. This gave information on a total of 125 melanoma patients, all of these being advanced unresectable disease, and they were treated at different doses on an every 2 or 3 week schedule. This showed a similar response rate in the 38% range. Again, this is both a shrinkage of at least 30% of tumors as well as complete disappearance of tumors. The response rate at the recommended dose currently right now, which is 10 milligrams per kilogram, and this was administered on an every 2 week schedule, was as high as 52% with a 10% complete response rate. This medicine was also tested in patients, both those who had never received treatment with Ipilimumab or those who had received prior Ipilimumab, and interestingly, the response rate was no different for both groups of these patients, suggesting that if you did not respond to Ipilimumab, that did not necessarily mean that you would not have a chance of responding to the other immune therapy, specifically a PD-1 inhibitor. Of note, there were durable responses, meaning long-lasting responses, where 81% of patients who had evidenced a response still had it at the time of their analysis. Side effects were similar to other trials, including fatigue, rash, itchy skin, as well as diarrhea, and the majority of the side effects were felt to be lower in severity or low grade. They also included patients with brain metastases in this study. higher grade treatment-related adverse events were at a level of approximately 12.6%. There were some reports of immune-related side effects, including pneumonitis or inflammation in the lungs, abnormal endocrine function, including abnormal thyroid function, as well as kidney dysfunction. Many of the treatment-related side effects were managed with stopping the medicine, supportive care, and occasionally steroid treatment. Right now, there is an ongoing randomized study that's exploring the different doses on an every 3 or 2 week basis compared with investigator choice therapy. Going back to Nivolumab, the PD-1 inhibitor for Bristol-Myers Squibb, additional data was presented in combination with a couple different treatments. First, there was a study presented by Jeff Weber that combined the PD-1 inhibitor with a peptide vaccine. I'm not going to reiterate all the details of the study, but there was several cohorts or small groups of patients treated, and of interest, there were patients treated who again had previously received Ipilimumab and did not respond. There was evidence of response to treatment with this combination, including where the response rate was at least 25%. Additionally, they included a small group of just 5 patients who had had side effects on Ipilimumab that were fairly significant in the grade 3 severity range, and those patients were able to be safely treated with the PD-1 inhibitor. Lastly, the combination study with Nivolumab that garnered quite a bit of attention is currently a publication in the New England Journal of Medicine, was presented by Jed Wolchek, and this combined Nivolumab with Ipilimumab. This is a phase 1 study that was made up of a total of 7 groups of patients. One set of cohorts involved people receiving both Nivolumab as well as Ipilimumab at the same time, what they deemed the concurrent cohort, and the other one was a sequential cohort where patients who had previously received treatment with Ipilimumab, the majority of which had actually been progressing despite treatment with Ipilimumab, then went on to receive PD-1 inhibitor Nivolumab within 12 weeks of their Ipilimumab dosing, and this was deemed the sequential cohorts. A variety of different doses was tested as this was a phase 1 study. In the concurrent treatment group, the overall response rate across dosages was 40%. Additionally, there were patients evidenced a quick onset of benefit as well as a significant durability of response, with the longest response to date at 72.1 weeks. Additionally, not only were patients evidenced response, but the degree of shrinkage was remarkable, where 16 of the patients on this arm, 31%, actually had a reduction in their tumors by at least 80% by week 12, and this included 5 complete responders. Of note, the treatment-related adverse events in this study in the higher severity range of grade 3-4 was approximately 53%, where the majority were reported to be lab abnormalities, including liver test abnormalities as well as lipase, which is an enzyme from the pancreas. These were treated per standard protocols and included treatment with steroids in some circumstances. Of note, 21% of patients had to stop treatment because of side effects. In the sequential group, there were a total of 33 patients treated, and the response rate was around 20%. There was a complete response, and again, patients did develop a significant amount of tumor shrinkage. If you included patients who did not grow but maintained the stability of their disease in this group, the overall benefit rate was a total of 43%. Toxicity was seen, but was in the higher severity range around the 18% range. The recommended phase 2 dose, which was the goal of this study, is currently Ipilimumab at 3 milligrams per kilogram, which is the current FDA-approved dose, and Nivolumab at 1 milligram per kilogram, and ongoing studies continue. Of note, the investigators evaluated whether or not the demonstration of PD-L1 expression or positivity in a patient's melanoma sample might predict whether or not they respond or do not respond to Nivolumab in combination with Ipilimumab, and they did not see a significant difference between those who did express this and those who didn't and their benefit from treatment. Lastly, regarding Ipilimumab, there was a randomized phase 2 study presented by Steve Hody from the Dana-Farber Cancer Institute that compared Ipilimumab on its own compared to Ipilimumab in combination with GM-CSF or sargramortin. This is a medicine that has been utilized, but at this point is not considered a standard of care in the treatment of advanced melanoma. Again, these were advanced unresectable melanoma patients, and patients with brain metastases were excluded. The dosing of Ipilimumab in this study was higher than the current FDA-approved dose at 10 milligrams per kilogram, and it included maintenance dosing after the initial 4 doses, such that they received a dose on an every 3-month basis until evidence of either side effects or disease getting worse. In review of the shrinkage rate or response rate to these agents, they were similar at 15.5% for the combination and 14.8% for the single agent. Median progression-free survival or time to the melanoma getting worse was equivalent at about 3.1 months. But interestingly, the patients who were on the Ipilimumab combination arm with GM-CSF had an improved median overall survival at 17.5 months compared to 12.7 months for Ipilimumab alone. Additionally, there was evidence of decreased side effects that were at a higher severity level for the combination arm versus Ipilimumab by itself. It is interesting to see an overall survival benefit in the absence of a difference in median progression-free survival, and one of the postulated ideas was that the GM-CSF may actually be making the Ipilimumab side effects more tolerable as opposed to improving the efficacy. As this is a randomized phase 2 study, I think this is certainly interesting results, but potentially a larger study may need to be done to confirm. Lastly, there was a preliminary data presented on a PD-L1 or PD-ligand-1 inhibitor antibody by Dr. Omid Hamid. This is similar to the PD-1 inhibitor, but it is targeting the ligand as opposed to the PD-1 molecule. There was data presented on another PD-L1 inhibitor last year. This is an ongoing phase 1 study that is looking at a variety of doses, and currently they presented information on 44 melanoma patients that have been treated to date. Happily, this showed another good response rate at 29%, and when you include patients who had not progressed at the 24-week mark, that benefit rate went up to 43%. Overall, this appeared fairly tolerable, and so far no evidence of pneumonitis or lung inflammation or colitis or colon inflammation have been described in this study. And he also shared that there is an ongoing phase 1 study that is combining this PD-L1 inhibitor with vemurafenib, the BRAF-targeted inhibitor. So overall, very exciting information. I think this continues to support the idea that immunotherapy is a real possibility. While we are focusing on melanoma right now, I think it is important to state that in all of these studies there is also data in a variety of other tumor types that is showing benefit of inhibiting these checkpoint inhibitors. Lynn?
Great. Thank you so much. That's a really great summary of the studies that were presented. So in the past, we've used immunotherapy. Many of you are familiar with medicines like interferon and interleukin-2, and previous studies with vaccine approaches. And those results have been somewhat mixed in terms of how well they work, and then some concern about the side effect profile of those medications. So this new approach that Dr. Fecher's just outlined is a different way of stimulating the immune system than how we've thought about it before. And this approach is taking the brakes off the immune system and allowing for a more rigorous expansion of T cells and revving up the immune system in a different way than what we've done in the past. So we were all actually really excited to hear about these results, and do expect that the PD-1 antibodies will ultimately be approved for treatment of melanoma, maybe as soon as in the upcoming year. The Merck PD-1 antibody did get breakthrough designation from the FDA, and so that leads the way for more rapid possibility of FDA approval of this drug to make it more available to patients. The only way to get access to the PD-1 antibodies at this point is to enroll on clinical trials, which are available nationally, and you can also check the MRF website or cancer.gov to look for clinical trials that might be available for you. So that was immunotherapy. The other approach to consider in treating patients with melanoma is targeted therapy. And the main gene that we consider with targeted therapy is a gene called BRAF. We've talked about this before on previous calls, and in about 50% of patients with melanoma, the BRAF gene is mutated or broken. And when the BRAF gene is broken, it stimulates the pathway, and it's like your foot's on a gas pedal driving the melanoma cells to grow. And there's a lot of research then in looking at drugs that put the brakes on. So the currently approved BRAF inhibitor is vemurafenib, also known as Zelboraf, and that was approved about 18 months ago, 2 years ago, for treatment of patients with advanced melanoma with mutated BRAF gene. So what was presented at this year's ASCO and drugs that were recently approved is a different BRAF inhibitor, dabrafenib. This is the GSK BRAF inhibitor. And the other agent that was discussed at ASCO and also FDA approved is called a MEK inhibitor, and the medicine is known as trametinib. So these are all, I know, complicated names that we're throwing out here, and honestly, I have a hard time saying a lot of these names myself. But presented at ASCO was a combination of combining a BRAF inhibitor plus a MEK inhibitor. So imagine a round circle, which is a cell, with dominoes, and in the same pathway that dominoes fall sits BRAF and MEK. And there's a lot of reason to think about combining BRAF plus a MEK inhibitor. So it's targeting the same pathway, sort of doubly targeting the pathway. And this study that was presented by Dr. Sossman on behalf of a large group was a study of patients with metastatic melanoma, so melanoma that's traveled, patients that had a broken BRAF gene. This was actually an update on studies that were previously have been presented or published. And this was looking at combining the BRAF and MEK inhibitor at a certain dose. And what the update from Dr. Sossman showed was again confirming that the combination of BRAF plus MEK was associated with a higher response rate than giving just the BRAF inhibitor alone. Now, this trial design, what we call a randomized phase 2, is not completely able to claim that one is definitely superior to another, but it certainly confirmed that combining a BRAF inhibitor may have more activity in terms of shrinkage of melanoma and prolonging survival than just giving the BRAF inhibitor alone. So certainly promising that what we call combi therapy or combination therapy might be superior to monotherapy. The other interesting thing is that when you combine the two drugs, you actually get fewer side effects or a slightly different side effect profile. So we do see with the BRAF inhibitors that patients can develop changes to their skin, a skin rash, the skin gets sort of thickened, there can be wart-like lesions, but also through a complicated reactivation of different pathways in the cell, actually patients can get squamous cell skin cancer. So while we're treating melanoma, the serious type of skin cancer, we actually can cause squamous cell skin cancer in about 20% of patients who take a BRAF inhibitor. Remarkably, when you combine a BRAF and a MEK inhibitor, actually reported again, was that there were much fewer squamous cell skin cancer. So when you add a MEK inhibitor, it actually prevents parallel stimulation of other pathways in the cell. So again, imagine dominoes. If you had a separate pathway, the MEK inhibitor prevents activation of another pathway in non-melanoma cells. So it's pretty amazing that you combine two drugs and maybe have higher efficacy and fewer side effects. I should mention that when the two medicines were combined, there is a slightly higher risk of fever. So the side effect profile is a little bit different when you combine the two than giving just one agent. So that was an update on the BRAF-MEK inhibitor study. And while we were at ASCO, or maybe a day before ASCO, the FDA did approve GSK's dabrafenib, the BRAF inhibitor, and trametinib, the MEK inhibitor, for patients with advanced melanoma. Now, what is FDA approved at this point is single agent use, or what we call monotherapy. So they approve that in patients with a broken BRAF gene, they can receive dabrafenib, and they approve that in patients with a broken BRAF melanoma, they could get a MEK inhibitor. But what is not approved is using the two together. We anticipate that using the two in combination will be FDA approved, we hope, in the upcoming year. The approval of that really requires completion of a larger study, which is has accrued the patients, but longer follow-up is needed. So one question is, with drugs that are FDA approved, are your doctors able to order the combination? I think it's unlikely that we're going to be able to order the combinations right now, or that insurers are going to cover using both agents. But we'll have to wait and see. What emerges, and these drugs haven't even gotten to the drugstores yet, or to the specialty pharmacies. In the studies that have been done previously, the BRAF inhibitor does look to be more active than a MEK inhibitor. So it would be a little unusual to pick a MEK inhibitor for BRAF mutant melanoma as a first-line treatment. So this was very exciting that we have additional medicines to treat patients with. And it's very clear that in all patients who have melanoma that is either can't be removed in stage 3 or stage 4, we must know whether or not the melanoma has a mutated BRAF gene. And that is tested by taking a sample of the tumor that's already in the laboratory, so it generally does not require a new biopsy. This is melanoma that's stored in the laboratory in wax or paraffin, and the DNA is extracted, and then the BRAF test and other genes can be determined from that sample. So it is very important for your care and for your doctors to know whether or not your melanoma has a broken BRAF gene, because that does open up a certain pathway in terms of treatment. I should mention also that there are ongoing studies that look at BRAF mutations in the adjuvant setting. So patients with stage 3 melanoma that has been removed surgically, there are ongoing trials that one could consider with a BRAF inhibitor. So even patients with earlier stages of disease, we are now beginning to test whether or not the melanoma has a broken BRAF gene. So this is very exciting to now have two different BRAF inhibitors available, vemurafenib and dabrafenib, and now a MEK inhibitor as well. Very important that we don't use these medicines in patients. We don't use BRAF inhibitors unless a patient has a confirmed BRAF mutation. So we wouldn't give it if we didn't know the mutation status, or if it was tested and it was what we call normal or wild type. So this is something that requires knowledge about the genetics of your tumor, and then we can apply this therapy. Unlike the immunotherapy, where it doesn't matter what the mutation profile is or the genes that are broken in the tumor, the immunotherapies, the PD-1 antibody, the Ipilimumab, also known as Yervoy, can be used regardless of what the genetic makeup is of your tumor. Switching gears in terms of what was presented at ASCO, there was an interesting paper in uveal melanoma. So uveal melanoma is melanoma that starts in the eye, which is very uncommon, but there are pigment cells that are in the back of the eye. This is called uveal melanoma or ocular melanoma. And this has been a very difficult disease to treat. Once it leaves the eye and travels, which it frequently metastasizes to the liver, it's been a particularly difficult type of melanoma to treat. And in a study led by Dr. Carvajal, who's at Memorial Sloan Kettering, and multiple sites participated in this study, they evaluated a MEK inhibitor, a different MEK inhibitor than what I just talked about, a MEK inhibitor known as selumetinib. And this study was designed as what we call a randomized phase 2. So patients who had melanoma from the eye, uveal melanoma that had traveled, their melanoma was tested for genes. And in uveal melanoma, it's a different kind of gene that's broken, something called GNAQ or GNA11. When those genes are activated, it stimulates a similar pathway that I've been discussing earlier. And in this study, patients either got standard chemotherapy with temozolomide or Temodar or received this MEK inhibitor. And what the results showed that there was a higher response rate, which is shrinkage of the melanoma in the patients that got the MEK inhibitor compared to chemotherapy. About a 20% response rate or shrinkage rate in patients getting the MEK inhibitor versus a much, much lower response rate in patients who got chemotherapy. So I think that while these are very preliminary results, I think it paves the way for thinking about targeted therapy in uveal melanoma, and certainly more studies are going to be done in this fashion for patients with uveal melanoma. And it's been remarkable, the advances in understanding the genes that are broken in uveal melanoma, as we've also been learning about the genes that are broken in ocular melanoma. So that was really, I think, an important breakthrough in terms of thinking about ocular melanoma. The last study that we're going to present, and then we'll open it up for questions, was a study not about these systemic treatments, but the role of radiation therapy. And one of the questions that we have is in patients who have had lymph node involvement from their melanoma, say underneath the armpit or in the groin area, if there are many lymph nodes involved, should we add radiation therapy to treat the groin area or the lymph node basin after surgery's been completed? And it's been a question that we have not known the final answer to. And so this was a study in which was largely done in Australia, and patients who had lymph node involvement, so stage 3 melanoma, were randomized to surgery alone or surgery plus radiation therapy. And the study showed that the addition of radiation therapy did decrease the risk of a local recurrence where the lymph nodes had been, but it did not prolong overall survival, and maybe a little bit more in the way of lymphedema or swelling of the leg in patients, or the arm in patients who had the radiation therapy. So I think this is probably going to be the last study done in looking at this question of the role of radiation therapy. And I think, perhaps in some patients it may be warranted, patients with many lymph nodes involved. But this added some additional information about radiation therapy, and it again showed a decreased risk in local recurrence, but it did not affect overall survival. So, of course, radiation therapy locally wouldn't be expected necessarily to have an effect on distant recurrence. So it was a lot of information we've just presented. We've presented an update on immunotherapy with the new approaches with PD-1 antibody and with combinations of therapy with immunotherapy. We've just talked about targeted therapy, mainly emphasizing approaches for BRAF mutant melanoma, and then briefly talked about the approach with MEK inhibitors for patients with metastatic uveal melanoma. I think we'll turn it, operator, over to questions, and I'm sure it's going to come up, how do we decide to sequence some of these medications? How do we decide which treatment to use first? But I'm going to open it up for questions, and we're happy to take your questions now. Thank you.
And at this time, I would like to remind everyone, in order to ask a question, simply press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster. And there are no audio questions at this time.
Okay, then I'll start. Leslie, can you tell me how you approach the question of sequence? So if you have a patient with a broken BRAF gene, BRAF mutant melanoma, how do you decide if you do an immunotherapy approach first or consider targeted therapies?
So, Lynn, it's always a tough thing, and I would say it's a little bit controversial still in our field. I'm a firm believer that there is not a set way that everybody should be treated. I think melanoma, as you well know, is very varied in the way that it can present, and is also varied in the types of patients it affects, and their other medical conditions need to factor into decision making. For me, one of the most important things is trying to get a feel for how much melanoma they have in their body, and if the melanoma spots are actually causing symptoms or problems. In someone who has what we consider symptomatic metastatic disease, pain from some of their tumors that are causing problems such as bleeding or difficulty breathing, those are people that we would want a response from medicine sooner rather than later. And in someone with a broken BRAF gene, I would then select a BRAF inhibitor or potentially a clinical trial with a BRAF inhibitor, possibly in combination with something else, as the first choice option, because the chances of shrinkage are fairly quick and they tend to have a rapid onset of action. At this point, if we talk about medicines that are available over the counter, the immunotherapy approach is certainly a valid one, even in people with BRAF mutations or broken BRAF genes. But the ones that we have available now tend to take a little bit of time to evidence a response. And so in someone who has symptoms from their tumor, I worry that I don't have enough time to wait for that response to happen. However, if I have someone with a broken BRAF gene and a small amount of tumor or not having symptoms from it, I would discuss some kind of immunotherapy, and that could be Nivolumab, it could be high-dose interleukin-2, or more likely it could be a clinical trial as well, either with a single medicine or combinations of immunotherapies. And the reason behind thinking about immunotherapies, even if there's a broken BRAF gene, is that there seems to be a longer-lasting benefit if we get a response from immunotherapies that is very appealing. And then we could always certainly consider BRAF-directed therapy at a later date.
Yeah, I would completely agree with that approach. And so we're frequently giving the immunotherapy first in patients who don't have a significant amount of symptoms, and then can use the BRAF inhibitor. So I would completely agree.
I think I also might make a comment on the trametinib and dabrafenib now being available that you had commented on earlier. I think this is a tough situation to figure out when we might use a MEK inhibitor, and I think it does bear stating that right now the MEK inhibitor is approved as a first choice option. So someone who's not with a broken BRAF gene, who has not been exposed to either a BRAF inhibitor or a MEK inhibitor previously. There is some limited data to say that if we try a MEK inhibitor in someone with a broken BRAF gene after they've had a BRAF inhibitor, that they do not derive any benefit. So I just wanted to make sure that we put that out there.
Good point. Shelby, do you have a question that you've been hearing from folks on the MPIP or from MRF?
Nothing's jumping out at me. The questions are vast, but nothing in particular is jumping out at me. I think one of the more common questions that I get is general in the way of just learning about clinical trials and being knowledgeable about them. So that's something that the MRF is really working toward to make that a little bit more crystal clear and easy to understand, and knowing that they won't be, participants won't be a guinea pig and receive a placebo in a clinical trial while everyone else is receiving medication. So it's some of the common myths that we're trying to clarify, but they're less specific than probably what we're talking about here.
But I think a really good point that you're bringing up, and I would say that enrolling patients on a clinical trial is my first choice. I think that is how patients get access to the newest approaches to treatment. And, with healthcare reform, it is to be that insurers cover the routine patient care cost associated with enrollment on a clinical trial. So some patients feel that, they hear from their insurance company that they're not going to provide coverage of enrollment on a clinical trial, but for the most part, it is covered, and I would let your healthcare team help advocate for you on this particular issue, because generally it's covered because the drugs are often provided free of charge. And Shelby, as you mentioned, it's uncommon that there's a placebo or sugar pill associated with the clinical trials that we've described for advanced stage 3 or stage 4 patients. And so I do think it's important that this is a very important option for patients. And as I said, gives them access to some of the most innovative treatments around right now. In patients with stage 3 melanoma that's been removed, there are a lot of exciting trials to consider. Those can sometimes be a little bit more challenging to enroll in, but again, would encourage your listeners to consider a clinical trial and ask your providers about, is there a clinical trial option available?
I think I agree with all that. Clinical trials are a big topic, and it can be a little difficult sometimes to figure out. Clinical trials are a moving entity, and so sometimes they're available, sometimes they're not, sometimes there's slots, sometimes they're not. One of the websites that can be particularly helpful, I think, for patients is the clinicaltrials.gov website, which can be easily searched, and there are always going to typically be phone numbers that can facilitate calling. One of the most important things to understand is that clinical trials are heavily regulated in an effort to protect the patients and people who participate, and so there are all kinds of checks and balances to make sure that it is a safe manner, and if somebody is having a side effect that is not considered acceptable, they wouldn't continue on to receive treatment if it was not considered safe. And so, and additionally, there's also a wide variety of clinical trials. A lot of the ones that I discussed today are actually very early clinical trials where we're kind of accumulating information on newer medicines. But then there's also studies that, as we all know, we need to test a medicine or a combination of medicines a couple times to ensure that we truly understand and have the correct information. And so trials that are later on in the development of a medicine have the benefit of having quite a bit of track record and knowledge about the drug that has happened before that in earlier studies.
Any questions? Leslie, I wonder if you could comment on where you see combination therapy going in terms of targeted therapy and immunotherapy.
Well, I think as I had said earlier, melanoma is a complicated tumor, and so I don't think that there's a single best approach, and I also think that there's a role for all of these different classes of medicines. Traditionally, we've kind of divided medicines according to how they act, so immunotherapy separate from targeted therapies, separate from chemotherapies, but I really think the future is not only in combinations within those groups, but also across them, and I think we're just starting to see some of this. The combinations of immunotherapies with targeted therapies, I think, potentially could be very exciting for the future. And so, I think as we better understand how to individualize treatment and select people for specific therapies, we'll then be able to kind of select the best regimen for them. In melanoma, we tend not to do kind of sequential therapy quite so much, but rather try and hit it a little bit harder up front. Now, obviously, that's not the right approach for everyone. And so the more we understand how best to predict who is going to benefit rather than trying it and then seeing what happens, I think the better outcome.
Great. Well, in caring for patients with melanoma for actually almost 25 years, I've never seen these kinds of drugs with this kind of activity in melanoma. And at this year's ASCO meeting, what was really remarkable was when the immunotherapy studies were presented, as Leslie just mentioned, the pace, the quickness of the response. Sometimes when we were using Ipilimumab or interleukin-2, it took a while to see the responses occur. But there were some reports of patients' tumor shrinking within 3 weeks of the treatment, and then how deep the response is, meaning complete responses that we're seeing, was also remarkable, and then the duration of the response. And if you think about treatment of melanoma prior to 2010, where we had interferon, interleukin-2, and DTIC, and now in 2013 what's available, it truly is a different landscape. I would say that education is obviously key, and thank you for joining the call today. This is how you learn about melanoma, you learn about treatment options, maybe not needed right now, but information for the future. So I think, unless there are any questions, we can end today's session, and maybe Shelby, you could wrap it up.
Sure, thank you. Thank you again, Dr. Schuchter and Dr. Fecher. Thank you to the participants for joining us. If you didn't feel comfortable asking a question, or if you think of one later, you can email us at education@melanoma.org, and we'll try to get that answered for you. And if we see them, that there are a handful, then we can post a PDF of the questions and answers, or I can simply just email you the answer. But we'll get that question answered for you. And a recording of this teleconference will also be posted on our website next week, so very quickly after we hang up today. We'll post that on our event page. So I just want to thank you all again for your participation, and thank you again to the speakers. And this now concludes the teleconference. I hope you have a wonderful afternoon. Thank you.
Thank you.
Thank you.